Bayfront started as a sanitarium, 5-bed sanitarium in the early 1900s, and then it became Bayfront in 1970. Second quarter of 2013, it was acquired by a for-profit company, which was later sold to another for-profit company. Led to a significant reduction in resources for the hospital. And then there was a high cardiac surgical turnover among the surgeons and the staff. It was acquired by Orlando Health in 2020, in October of that year. And at that point, there was a lot of investment in the infrastructure and change in direction in the program. Well, the first step taken was a frontline process. Interview of the CVICU leadership and staff, anesthesia, perfusion, the PAs, anyone involved, any of the stakeholders involved in the cardiac service line. And once I was able to identify the problems, then we began our process of rebuilding the program into a culture of safety and accountability.
We wanted to make sure that our preoperative testing was succinct, and when we identified potential problems, as minuscule as it may have seemed at that time, that we addressed it and we answered the question. We also tried to lay out a treatment plan with our ancillary support teams to maximize patients' outcomes post-surgery to keep them moving.
I decided to establish a model that was similar to what you see in larger programs, multidisciplinary care. Collaboration leads to better patient outcomes and also better longitudinal care for the patient. One of the first things we did was re-engaged our consultants, particularly critical care, to manage the patients in the perioperative period. We also established a set of expectations for our CVOR as well as our CVICU. We established closed loop communication, whether it was in the ICU or in the CVOR. And I attend quarterly meetings for the CVICU staff to make sure we're on the same page, identifying any gaps, any problems, and any new processes we want to institute.
The strategies and approach that it was used actually was to evaluate all the protocols, including ventilatory support protocols, extubation protocols for rapid sequencing, evaluate the patients in a collaborative way, discussing the case with thoracic surgery, cardiology, and pulmonary and critical care. As most of the patients with heart disease, most of them has a history of tobacco abuse and underlying lung disease.
The collaboration team goes all the way from the senior team in the front office of the hospital to the bedside nurse. There's been a buy-in by cardiology, critical care, nursing, senior team, pharmacy, everyone in the hospital. It's been the goal of everyone to elevate Bayfront back to where it should be.
So over the last year that I've been here since January, I've managed to improve outcomes by working closely with our cardiothoracic surgery colleagues. For one example, I do lead extractions. Those can be a high-risk procedure, though overall mortality should be very low. For example, we perform these procedures together, both of us scrubbed in kind of a hybrid OR room. So that's kind of one way in my particular field that we've improved mortality outcomes. Another thing is we get involved early in the post-operative state for early onset arrhythmias post-surgery, where we get involved very early to help manage that with the surgeons.
I think the benefit to having everyone collaborate is the improvement in perioperative care of the patient. It also provides continuity of care, particularly for the cardiologist. They're involved in their care during the hospital stay, and now they know what has occurred during hospitalization and can continue the care post-operatively. It's allowed us to expand our service offerings to involve things like initiate a cardiogenic shock program in its early infancy and other programs within the hospital, because we are now collaborating and everyone is on the same strategic vision. As a result of the reforms that have been made, we have seen a reduction in mortality, an improvement in our ventilator times at both the 6-hour and 24-hour mark, reduction in renal failure, and reduction in reoperation. We've been able to attract and retain new talent because of the culture that's been established in our CVICU, where safety and accountability are held at a priority.
I think the interplay between cardiology, anesthesia, and critical care is essential for kind of a proper full-service cardiovascular team in a hospital. We manage a lot of complex patients. These patients are getting even more complex, whether it's from an arrhythmia standpoint, a valve standpoint. So if I'm seeing a patient for, say, atrial fibrillation, it's just as important that their mitral valve, if they have mitral regurgitation, that's handled. We do a lot more advanced procedures now on sicker and sicker patients. So if I'm doing an ablation or an EP procedure on a patient who has, say, bad lung disease or bad valve disease, the anesthesiologists are just as critical in getting them through the procedure safely. And then on the opposite side, in the unit, the critical care team is invaluable to kind of help manage the patients post-operatively or even preoperatively.
I have discussed with the electrophysiologist a formal arrhythmia program. Today, there are many hybrid procedures being done for management of arrhythmias, and we have a very talented group of electrophysiologists. And in order to offer the community the most cutting-edge technologies and therapies, we are collaborating on lead extraction, also management of atrial fibrillation and other arrhythmias, both surgical and percutaneous in the cath lab.
Looking at where we were in 2020 and 2022 and how we have improved in just 3 years, I think the future is pretty bright for Orlando Health. I think it's going to be the hospital for the community here. They can do all the lines of services are here, from thoracic surgery to cardiology to pulmonary to advanced lung procedures are here.
I would like to see the services and skill sets provided at our institution very similar to what we have at academic institutions, where we do the groundbreaking research, where we have a lot of our more sicker patients that we can accommodate with our specialty staff.
Well, in the future, we are already ready to recruit another surgeon. I think within the next 18 months, we'll probably have an adult congenital heart program with the Johns Hopkins group. That's something that's been in the works for the last few months. I think within 12 months, my hope would be that we are able to have a full cardiogenic shock program with ECMO. And I think within 12 months, we'll also have an arrhythmia center with lead extraction formalized. The future for Orlando Health Bayfront Hospital is extremely bright. I believe everyone has bought into the vision to make this a top-tier referral center in southern Pinellas County. And I believe our reach will go even into other areas outside our own county.